Good afternoon. My name is Rhonda Workman. I'm with the Developmental Disabilities Administration. I want to welcome you to the Waiver Advisory Council for the Developmental Disabilities Administration. I serve as one of your co-chairs, and with us today is?
I am Charlotte Friedner-Whitaker. I am the other co-chair of this council, and I am a participant of the waiver and have been self-directing since 2017.
I'm going to now turn it over to Dr. Smalls to share some of the housekeeping with us.
Before beginning our meeting, we also want to ensure the civility for all meetings. The free expression of diverse viewpoints is a fundamental value of our group. This freedom carries the responsibility to engage respectfully, which means treating one another with dignity and respect in good faith. Uncivil behavior, disruptive conduct, abusive language, threats, or harassment will not be tolerated and may lead to being excused from the meeting. Thank you for helping to keep this productive and comfortable for everyone. If you would like to use closed captioning so that you can read what is being said, click this button. Sometimes the transcription is not exact, but it's pretty close. All attendees are currently in listen-only mode, and your mics and cameras are turned off. Today's presentation is available in the handout section. Click here where you see the paperclip. Click here where you see the paperclip to download the presentation slide deck. If you have a question and you would like us to read and answer, click here where you see the slide with the question mark to add your question. If you would like to ask your question aloud during our comment section, please click this button to raise your hand. We will invite you to unmute during our public comment section of today's presentation. And now I'd like to introduce you to our Director of Federal Programs and Co-Chair Rhonda Workman, who's going to begin today's meeting.
Okay. The purpose of the Waiver Advisory Council could be to provide input on DDA operated Medicaid waiver program system design, service delivery and access to services, federal waiver assurances, ensuring access to Medicaid services, and quality enhancement efforts and improvement strategies.
Thank you, Charlotte. Can you go to the next slide, please? We also wanted to review our ground rules that we review before each meeting. Ground rules are sometimes referred to as rules that are things like respect, respectful for other participants, not interrupting, and staying on topic. So for our advisory council ground rules, we shall all assume positive intent, speak one at a time, use plain language, share information openly, listen to different points of views, stay flexible and open-minded, participate actively, engage respectfully and politely, and minimize distractions. Next slide, please.
Thank you, Rhonda. Good afternoon, everyone. My name is Robert White. I am the Chief Operating Officer for the Developmental Disabilities Administration. And on behalf of the Maryland Department of Health, I want to thank you again for your partnership, your feedback, and your commitment to enhancing the DDA home and community-based services waivers. I'm going to turn it back over to our co-chairs to get things started. Rhonda and Charlotte.
Thank you. Can you go to the next slide, please? So this slide includes our agenda for today. We're going to take a vote for the approval of our December, February, and April meeting minutes. We're going to then provide updates, DDA updates on a number of topics related to the purpose of the advisory council that Charlotte had shared with us. Charlie's going to share an update on the work group for people with lived experiences. Karen Lee is going to share an update related to the waiver amendment or the waiver recommendation work group updates. We'll also touch on public comments and actually open that up today for additional public comments, not only from the council, but from those that are joining us today. And then we're going to move a few items around in our agenda to kind of keep everything related to the waiver amendment together. So just bear with us from that perspective. Can you go to the next slide, please?
So quorum was not obtained for December and February meeting minutes. Does anyone have any amendments they would like to bring forward? If so, would anyone like to vote to approve December and February meetings minutes?
Mary Janzek has a question.
Mary, okay. Mary, go ahead. Mary, do you have a correction to the minutes? Okay. So I believe Charlotte's asking, can we get a motion for the approval of the December, February, and April minutes?
I make a motion.
Okay, sorry.
Okay, I'll second.
Okay,
All right.
thank you. Can we go to the next slide, please? So for today and our future meetings, we're going to include updates related to the various areas the council provides input on. And Charlotte reviewed those just a few minutes ago. So again, it's the DDA operated Medicaid waiver program, system design, service delivery and access to services, federal waiver assurances, ensuring access to Medicaid services, also referred to as the access rule, and quality enhancements and efforts and improvement strategies. Can you go to the next slide? So our first update is going to be in regards to the DDA operated Medicaid waiver program system design. And more specifically, we're going to share additional information related to the proposed waiver amendment. So I'm going to turn it over to Robert to start the discussion.
Great. Thank you, Rhonda. Again, my name is Robert White. We would like to use this opportunity to do a few things. First, we'll share what we have been hearing from our community regarding the proposed waiver amendment, as well as provide additional information and clarification. We'll then discuss DDA's planned stakeholder engagement forum, scheduled for next Wednesday, July 2nd, 2025, and solicit feedback and dates from you on topics that and ideas from you on topics that should be part of that session. The session is being scheduled for 90 minutes, and we expect to spend at least 60 minutes interacting with or engaging with our stakeholders. I can't underscore enough how important your perspectives and look forward your perspectives and experiences are to shaping our services. It's not only important, but it's essential. And this is something that we've been underscoring during the webinars as well. We'll also highlight several important changes designed to positively impact the lives people choose to live in their communities. We're genuinely excited about these enhancements and look forward to building upon them together, recognizing this is an ongoing collaborative process. Finally, we'll provide you with resources related to the proposed application changes. We invite you to review these resources thoughtfully and offer your ideas and suggested alternatives to help DDA meet CMS technical requirements and federal regulations in ways that best reflect our shared vision and values. So with this spirit in mind, we will begin. Next slide. So what are we hearing? Before we dive into discussing what we're hearing, we'd like to provide a brief overview of how we've grouped the proposed waiver changes. This will help to facilitate our conversation. So we've organized them into 4 different buckets or groupings. The first are related to the state mandated changes. So basically what was in the budget bill. And then the second is the federal requirements covering important areas such as health and welfare assurances, safeguards, and other mandatory guidelines. The third is DDA guidance and policy alignment. So changes aimed at ensuring consistency across our policies and practices with the waiver. And then other CMS requirements. These are additional areas where CMS provide direction, but they're not very prescriptive in how we meet those assurances. And so with those, the state has some flexibility. And I think that's where we would want to spend the majority of our time. Those are, we put out there how we think we should go about meeting those requirements, but we also want to hear from you all what your ideas are in helping us come into compliance with those requirements. Next slide. So there are probably things that many of you are hearing as well, and we want this to be an iterative dialogue as we continue to move forward. We'll start by walking through some things that we have heard, which may also spur other things from you all that we'd like for you to share with us. Or am I on the wrong slide?
Do you want her to go back 1 slide, right? Can you go back 1 slide? Thank you.
Okay. And so what we're hearing is that, you know, DDA went beyond what was prescribed in the budget bill. We've heard concerns related to supported decision-making. We've heard concerns related to awake overnight changes, concerns with day trips no longer being billable, questions related to peer advocacy training, and questions related to the use of community development services or CDS for disability-specific activities. So first we'll talk about the budget bill items that require a waiver amendment. The first part of the budget bill relates to dedicated hours. It restored $51.9 million to preserve dedicated hours, but also required that the DDA decrease the funding percentage by 1%. So the proposed amendment will allow the DDA to decrease the funding level from 86 to 87%. The second one relates to the geographical differential paid to providers providing services in Calvert, Charles, Frederick, PG County, and Montgomery counties. It preserves the differential by restoring $37.7 million, but it requires us to cap the geographical differential at 10% above the rest of state rates. The proposed waiver amendment will allow us to do that. The second one here is related to, this one impacts the self-directed services model. And the MGA gave $7 million for us to move the day-to-day administrator role out of IFDGS to make it a standalone service. And the waiver amendment will allow us to do that as well. This next item is related to the Budget Reconciliation and Financing Act of 2025. And it strikes the section of the SDS Act of 2022 that restricted the DDA's ability to put a cap on IFDGS. The proposed waiver amendment will allow us to reinstate a cap on IFDGS. The total cap is $5,500, $500 of which is dedicated to recruitment and advertising for staff. Next slide. The following two budget items do not require a waiver amendment, but we have received enough feedback that we want to take this opportunity to provide some clarity. The first item relates to the reasonable and customary rates that employers can pay their staff in the self-directed services model. This language includes $36 million for the purpose of maintaining the reasonable and customary rates at the what they were back in November of 2024. So no changes to the rates. With that, the DDA did not take any action, and the reasonable and customary rates remain unchanged compared to the wages that were in effect in November of 2024. The second item does require the DDA to take action, but did not require a waiver amendment. And this has to do with the wage exception rates. The General Assembly put $12.7 million in our appropriation for the purpose of allowing wage exceptions for self-directed services, but they require that we cap it at 15% above what the max reasonable and customary rate is. So we've seen feedback where folks have taken the reasonable and customary rate excerpt from the budget bill, and there seems to be some confusion as it relates to the wage exception rate. So no changes to the reasonable and customary rate, but cap on the wage exception rate. So that's the key difference there. So it didn't require a waiver amendment. We developed and we posted the new wage exception rate as prescribed in the budget bill, capped at 15%. And then there's a geographical differential wage exception rate that's capped 10% above the rest of state wage exception rate. So with that, I am going to turn it over to Rhonda to talk about some of the amendment proposals that are based on federal requirements.
And before we get into that, just going to pause. So for council members only at this time, do you have any questions about what Robert just presented in terms of the state mandated for the budget bill and the Budget Reconciliation and Finance Act that he just reviewed? Just looking to see.
No, none at this time.
Okay, great. Thank you. All right. So as Robert mentioned, then the next category we want to talk about is federal requirements that require us to do a waiver amendment. So if you can go to the next slide, that would be great. And as we share this information and subsequent information, I just want to emphasize through the public comment process, we are looking for input from the public, including the council. That also includes alternative strategies. So as we're talking about what we're proposing to address the federal requirements, health assurances and safeguards, if you have an alternative strategy or something else that you think we should consider, that's what we're also looking for in the public input process. So really share your ideals and recommendations as we go forward. And our goal is to, continue to support participants while we're also meeting the federal assurances to be in compliance and to not risk any risk of losing federal funds. So just keeping that in mind, again, we want to encourage you to share alternative suggestions. So if we can go to the next slide, that would be great. So I'm going to share a few slides that relate to the new federal requirement for the use of legally responsible persons, legal guardians, and/or relatives. And so I'm going to put them in a group of these kind of special legally or legal or associated people, as we talk about this. And so currently in our approved waiver programs, we provide the opportunity for these individuals to provide services and supports in a variety of our services and supports in both service delivery models for 11 of our waiver services. So that's currently approved in our waiver program. And the other thing to note is in our waiver program, it currently states that these groups of people that we're talking about can provide up to 40 hours per week of services unless otherwise authorized by DDA. So currently in our program, 11 waiver services can do it, both service delivery models, up to 40 hours per week. That's currently what we have in our waiver programs. And so what's happened is the Center for Medicare and Medicaid Services, which is the federal entity that we work with and have the agreement, the contract with to provide these services, has issued new requirements, new standards and elements that we have to include in our waiver application and proposal. And so those are the things that we're going to talk about. They have reflected in the updated technical guide. And in our resource section, we've also included a recent PowerPoint presentation from the federal government that outlines the changes that occurred that we'll share at the end. So if you can go to the next slide.
Samantha, we do have 2 hands raised, it looks like from our council members.
Okay. If I could finish going through this part and then we will go to those questions just because we started, that would be great. Thank you. So what we're going to share on the upcoming slides is both the Center for Medicare and Medicaid Services technical guide requirements and our proposed waiver amendment. So for this one, related to legally responsible persons, legal guardians, and relatives, the new requirement that we have to address in our waiver application is the method for determining the amount of services provided by these groups of people, legally responsible individuals, legal guardians, and relatives. And this includes extraordinary care, which is exceeding the ordinary care that would be provided to a person without a disability or chronic illness of the same age, and which are necessary to assure the health and welfare of the participant and avoid institutionalization. And for our amendment proposal, we are proposing to add a request form for the use of these groups of individuals, legally responsible, legal guardians, and relatives. So we're able to track, trend, and report out on the use of those, and to also ensure, as per the Self-Directed Service Act of 2022, that an independent support broker is utilized, which is a requirement under the Maryland statute. Next slide, please. Also, the federal requirement requires us to include the state's process to ensure that legally responsible persons, legal guardians, or relatives who have decision-making authority over the selection of waiver service providers use substitute judgment on behalf of the individual. So these are individuals that they're not participants making their own decisions. These are other people that have decision-making authority over those providers and types of services. Substitute judgment is a legal tool that can be used when a person needs assistance in making decisions about their care or property due to their inability to fully understand a decision that needs to be made or inability to communicate a decision. So what we propose in our amendment to address this new federal requirement and to ensure and support the rights and decisions of participants self-directing their services and also using the other model, and also to avoid conflicts of interest, that we would have those individuals, the legal guardians, legal responsible person, relatives, those individuals would not be making the direct decisions related to the service delivery, the services and providers, and that the participant could utilize a supported decision-making agreement and have designate who they would like to support them in making those independent decisions.
Can I interject? I would also, when we're going through these slides, we're showing you what we're trying to come in compliance with and how we plan to do that. this is where we'd like for you to kind of think of some alternatives we can take into consideration. I would also add that Rhonda has also put a request into one of the listservs that we belong to try to get a sense of what other states are doing to come in compliance with this as well.
Thank you, Robert. And as he said, the other parts that I had in my talking notes is we are interested in your recommendations. So this is what we were thinking is the supported decision-making tool. It was passed by Maryland law. It's a great opportunity to support individuals and to support their voice and also address some of those potential conflict of interest. We do have several individuals that have decision-making authority, relative, legal, responsible guardians and legal guardians, who are also paid providers under the Medicaid program for their participant. So there's that conflict there. So again, please think about that, and we're interested in hearing your ideas so that we can not only meet the federal requirement, but to support individuals and their rights and voice. You can go to the next slide, please. Another requirement that CMS has is for us to note any limitations on the circumstances on which payment could be made and authorized for services to be paid for these groups of individuals. First, it's important to note, again, that we currently have a limit of up to 40 hours per week unless otherwise authorized by the DDA. And so our amendment proposal is to continue to support up to 40 hours per week for relatives, legal guardians, and legally responsible individuals. And that we would add that this includes when the person is serving not only as an employee for that participant, but also serving that same participant as a vendor. So they're just using two different provider types, but providing services. And that we are also proposing adding a provision to exceed the 40-hour limit due to circumstances that we refer to as emergencies, unplanned departures, and temporary exceptions, which will then provide further support for individuals and their health and welfare. We are looking for individuals to access their backup plans and emergency plans, which should be established in place, but recognizing that sometimes those may not be available at that time, we have proposed these additional options. And in our waiver, we note that a brief or temporary exception would be authorized up to 90 calendar days in any fiscal year in the event of emergency or unplanned departures. And we also had proposed in the waiver application, again, that language related to accessing the backup plan and the emergency plan prior to requesting that. Those requirements currently exist for a backup plan, which is noted in our DDA funded participant rights and responsibilities requirements. We also know that our DDA providers are required to have organizational structures to support in the event that their staff is unable to be there, so they have backup strategies. And so what we propose is for participants to submit an overtime request form in the event that that may be needed to exceed the 40 hours. The request can be approved before services are provided, and this would be in alignment with the current self-directed services manual and policy where we utilize a form for overtime. Can you go to the next slide, please? And then in addition to those requirements, we are also asked to provide any additional safeguards the state implements when a legally responsible person, legal guardian, or relative provides the services. And so in addition to those items that I just shared, as per our current requirements, we added that our coordinators of community services would conduct quarterly monitoring and follow-up activities, which includes currently them assessing service delivery and participant satisfaction and health and welfare. You go to the next slide. The application also asks us to include the procedures that are used to implement required state oversight, such as ensuring that payments are made only for services rendered. We currently utilize a entity referred to as a quality improvement organization. You may have seen information that we've been sharing in our webinars. Liberty Healthcare is our quality improvement organization. And so what we added to the existing language in the approved waiver application is the word designee to reflect the quality improvement organization or Liberty Healthcare in terms of the work that they do for us. So annually, the DDA or the designee would conduct random selected sampling for services provided by legal guardians, legally responsible people, and relatives to ensure that payments were made only for the services that were rendered in the best interest of the participant. So I have a few more to go through, and then we will go to some of the questions about this section. So the next slide, please, refers to the technical guide requirement related to specifications of the scope of services noted in the technical guide. And so in the technical guide, it will provide some examples of various services that are typically provided under home and community-based services. There's optional services and statutory services, but there's a section that relates specifically to the scope of services on page 128, which specifically notes that any services included in the waiver application, that services that are diversional or recreational in nature will fall outside the scope of the 1915C authority. Our Medicaid home and community-based waiver programs are under the federal 1915C authority. In addition, it notes in the technical guide, with some exceptions, that the funds may not be employed to pay for room and board expenses, and so that's already a limit and restriction within our program. And also it notes that services cannot be included to acquire goods and services that a household that does not include a person with a disability would be expected to pay for household expenses. So for our amendment proposal, we added that specific language or restrictions to the individual and family directed goods and services, where we have individuals using funds to purchase goods and services. And so we want to make sure that we're in compliance with the federal government requirements related to those exclusions for 1915Cs. Next slide, please. The technical guide also includes a new section referred to as Appendix C-5. It relates to what they're referring to as the home and community-based settings requirement. So several years ago, CMS issued a federal rule related to home and community-based setting, where they described and required standards and evidence related to what would be considered a community setting versus an institution or segregated setting, and also noted rights of individuals when they're living in residential settings. And so in the in the technical guide and the federal rule, it notes that requirements for services to be integrated in and support full access to the greater community. This includes opportunities to seek employment and work, which is we highly support. That means competitive integrative employment and competitive integrated settings. The setting should support engagement in community life. Individuals under the settings rule have rights to control their personal resources and receive services in the community to the same degree of access as individuals not receiving Medicaid and home and community-based services. And so we know that this means that the services and the settings must be integrated in and support full access for the broader community, offering meaningful interactions with people, both with and without disabilities. And so what we included in our proposal under individual and family directed goods and services, for which individuals are using funds to purchase activities in the community, that those activities and situations, that those fees must be community programs, and they must be activities that are inclusive and promote socialization and independence. The reverse of that would be that we're noting that goods and services does not include programs and activities that are exclusive for the individuals with disabilities. Next slide, please. And so another section that we're required to have information and standards are relates to assuring participants' health and welfare. And so a Medicaid waiver program design must provide for continuously and effectively assuring health and welfare of waiver participants, and this is noted in the Code of Federal Regulations. This includes the requirement for us to specify or to note in our waiver programs qualifications of waiver providers and to verify that providers continuously meet those qualifications. It includes monitoring the implementation of service plan and the participant's health and welfare. We have to have information in our waiver application related to identifying and responding to alleged instances of abuse, neglect, and exploitation, including financial exploitation, and instituting appropriate safeguards concerning practices that may cause harm to the participant or restrict participants' rights, such as restraint and restrictive techniques. So the renewal of the waiver, okay, for the waiver applications, which we have to do every 5 years, is contingent on the Center for Medicare and Medicaid Services determining that the state has effectively assured the health and welfare participants during the period that the waiver was in play. Next slide, please. So this slide includes a few examples of participant health and welfare safeguards for which we have proposed and are seeking your input and other recommendations. The first relates to awake and overnight staff, that we have noted that we are proposing that the overnight staff should be awake and alert. And the authorization and payment for overnight support services, we feel, should be provided by alert and awake staff to immediately address health and safety needs of the individuals. In terms of support brokers and day-to-day administrative supports, we have proposed limiting them up to 40 hours per week. We've already talked about other services are limited up to 40 hours. And this would be to support timely and quality services to participants and also to ensure financial accountability and integrity. Next slide, please. The waiver also requires safeguards. And so safeguards are defined in the technical guide, include state policies or procedures that are designed to prevent harm to an individual or to ensure that the application of a policy takes into account potentially adverse effects on a person. Information related to safeguards can be noted in various sections throughout the waiver application, and responses to those questions we have already noted. You go to the next slide. One of the things that we wanted to share, because of the questions we received, relates to the safeguards for termination of a participant from the self-directed service delivery model. So, as per the technical guide noted on this slide, the waiver must provide safeguards to prevent the premature depletion of the participant-directed budget. That's that individual self-directed budget that is authorized. And safeguards must be included that include flagging potential budget over expenditures or budget under utilization. And this provides also the provision for additional supports that may help and prevent involuntary termination of participant-directed services. So in our proposal, we have noted that we would like to add overutilization of authorized services as a reason for termination from the self-directed model. Overutilization is when a participant authorized services or payments that exceeds the services authorized in their person-centered plan or their self-directed service budget. We also propose, as one of those safeguard requirements, to have noted that in instances where a person may overutilize their services, before involuntarily terminating the person from the self-directed service model, we would may first have the option to require the person to meet with the DDA and their team to review their rights and responsibilities, including the rights and responsibilities for monitoring and the usage of their funding for authorized services. and/or we could require a corrective action plan for the participant. Next slide, please. The following slides is information related to what's currently in the waiver application. This is our current process and standards in the approved waiver application. A person may choose to involuntarily disenroll from the program, the self-directed service delivery model, and the coordinator of community services would help the individual to transition to the community provider managed service delivery model, and that would include selecting the providers. The DDA also has the authority to restrict the availability of self-direction or to terminate, meaning involuntarily terminate someone from the model. And we noted specific reasons. So currently in our waiver application, we have the following reasons. The person no longer meets eligibility criteria for the waiver. The person's person-centered plan has not been submitted to the DDA for review and approval in a timely manner. And this failure is attributed to the participant, their team, legal guardian, or designated representative. Also, the participant does not receive services under the model in accordance with the participant's person-centered plan and annual budget for 90 days or more, with the exception of extenuating circumstances. Can you go to the next slide, please? This includes additional reasons such as the health, safety, and welfare of the person is compromised by the continued participation in the self-directed model. The rights of the participants are being compromised. Failure for the person, their team, legal guardian, or designated representative as applicable to comply with any of the federal, state, local laws, regulations, policy, and procedures. And failure of the person, the team, legal guardian, and designated representative to manage funds within the approved budget, including expending or attempting to expend funds inconsistent with the DDA approved annual budget. In terms of managing the funds within the approved annual budget, as we noted before, some individuals are overutilizing or over-authorizing and spending those services. That's why we propose adding that one with the safeguard to be able to have meetings with them before termination and to review rights and responsibilities and to seek a potential corrective action plan. Next slide, please. It's also important to note that in the waiver program, in the waiver applications currently, in the event that an individual is terminated from the model, that they would receive information in writing about the date and the basis of the determination. And they also have the right to a Medicaid fair hearing as described in the waiver application. And again, the coordinator of community services, that case manager, would be assisting the individual and their team to develop a transition plan that would include strategies to ensure the continuity in services and health and welfare of the individual. So we're going to pause here and open it up to the council members for any questions or comments related to our proposals for the new required federal requirements for legally responsible individuals, legal guardians and relatives, the awake overnight, the day-to-day support broker limits, and the termination of participants. So I see we have Karen Lee.
Oh my God. Yes, several questions in the chat. And I accidentally sent it to Karen Lee.
Karen, we're unable to hear you. Can you unmute yourself?
Okay, I'm sorry. I thought I was unmuted.
There
Can
you
hear
are.
me? Yep. Okay, sorry. I just want to say that in the chat, people, it's not like Zoom where it goes to the whole panel. It automatically goes to the last person that spoke. So you have to make sure that it goes to organizer and panelists, because a lot of these comments people are making in the chat are coming to me directly. So go back, please, in the chat to make sure that if you had sent something, that it went to organizers and panelists and not to me. So that's the first thing. Thank you. And thank you, Rhonda, for the explanations. That was great. And I also asked a question about roll call, and I understand that we do have a quorum and that a roll call, even though we didn't do a roll call, you guys have been checking and we are at a quorum. So I appreciate getting that feedback. My question came before you started this last section, and I think because we're new to hand raising in this forum, it didn't get noted, but I have a couple of kind of bigger scale questions, which is number one, what do you do? And I'll ask these and then you could just, I'll get off and you could answer them. What do you do with the feedback? Is the feedback public? Do you respond to each piece of feedback? And if you don't use the feedback, do you ever tell people why?
Yeah, Karen, so great question. So a couple things related to the public input process. We will continue to utilize the process we have used for our renewal and our amendment. We review all feedback that is received. We have started receiving feedback, I think, the first day that we announced it. So the team is monitoring that and we're capturing that information. What we'll do with that information is then once the public comment period ends, we will look at all that information and summarize those in terms of themes, in terms of recommendations and comments. So as we currently and have done previously, we will do that. We post on the dedicated website a summary document that will note a summarize of the comments or recommendations that we got, whether they were accepted or not, and then a department response in terms of why we did or did not accept those. We do not include every single comment we've got, nor do we respond to every individual that we receive that, but we do consider every comment and recommendation that we receive, and we'll continue to provide a document that's specifically noted for public input comment summary. In addition, that information and a summary of that is included in the waiver application that goes to CMS because they will review that also.
Thank you, Rhonda. And I also really appreciate how you broke out this presentation in the kind of the 3 different categories. So thank you very much.
Thank you. All right, other council members that have questions? Is Mary the council member?
No.
Okay, I think, so right now we're going to be addressing council member. We'll open it up to you.
I have bad connection. This is Stephanie. Is that who you said? I cut out. So Rhonda, could you repeat the definition of overutilization?
Yeah, so overutilization, right, means that we have so individuals have a person-centered plan and authorized services for specific items. With the exception of some of the flexibilities within the self-directed service model, some individuals are exceeding those authorized services in their person-centered plan or noted in their budget. So I could ask Dr. Smalls to come and work Saturday after she's already worked the normal hours and I've used my hours or whatever that service is for the week. And I could authorize that even though it does not align with my authorized services or my budget. And so there are some individuals that are overutilizing their services and their budget, and that's what we're addressing.
But what you just said there, so if an individual, like there's always been flexibility, right, for providers and for self-direction. An individual might be sick one week and then need a few extra hours another week. There's always been that flexibility. Does this mean that if you now send a schedule in, right, and because none of us knows in June what life will be like next May, but we've sent a schedule in a year ahead of time for what we think our world's going to look like. So are you now saying that if we break that schedule, if an individual uses their hours a little differently, as long as they're still within budget, but the fact that they haven't stuck to their schedule, that is considered overutilization?
That's a great question, Stephanie. No, that is not what we're saying. I did not mention anything about a schedule. So what I was talking about again was services that are authorized in the person-centered plan or the funding authorized in their budget. That's what we're talking about, overutilization. We are not talking about when an individual may change their schedule or their activities for the week. They would need to stay within their authorized plan and budget. Thank you for that question. Any other questions from council members? Beth in the room.
Yeah, this is Beth Benavides. I have a question. Well, I have I have a comment and a question. A comment is on the safeguards that were mentioned and adding in that DDA would require a participant to meet with them and talk to them about reviewing their rights and responsibilities and so forth. And as it's written here, it says that DDA may, in its sole discretion, decide whether they're going to require this of a participant. And I believe that should be shall. I do believe DDA shall meet with a participant if there has been overutilization or underutilization, and give them the opportunity to speak to somebody from DDA about it and try to correct that. So I don't think it should be up to DDA to decide whether it does or not for a participant. So
Okay,
I would
thank you for that recommendation.
I would replace may with shall. And then the question that I've heard a lot from participants is with regard to the goods and services and equipment that can't be recreational. Are we talking about gym memberships or are we talking about bowling? Health and well-being versus an activity for pleasure.
Yeah, I'm happy to further connect with Medicaid on that. Do you have any recommendations that you'd like to share?
I think that many people have in their budgets to have physical activities in different ways that they enjoy for health and well-being, as opposed for just purely recreation. And I think it's kind of a gray area here if we're not clearly defining what's what. And then who is choosing that? If we're truly person-centered, to be up to the individual to choose what they're doing to promote their health and well-being.
Yeah, and please note that we absolutely support the health and well-being of all participants. Both recreational, social activities, gym membership. I'm a big component of being physically fit. But please note, as per the waiver or the federal 1915C Act, we would need to comply with that. So individuals, we absolutely want them to do that. We recognize that we're one of many resources that can support individuals. There are other resources and programs. People have personal funds. There are also discounts or other activities. But for what we could provide under the Medicaid program, we have to make sure we're in compliance with the 1915C.
So would that be defined then?
Yes, I'm hearing your recommendation for us to define
to define it. Okay, thank you.
Yep, thank you. Okay.
Oh,
Yeah.
sorry.
Go ahead, Matt.
Sorry, this is Matt Morgan. The substitute judgment concept, that whole thing, so it seems like it reads as if someone who does not have an intellectual disability is, it's presumed they're exercising their own decision-making authority, so they would not need support in decision-making or whatever. But in situation, obviously that's a scale. And so how would the determination be made over who is a person who is truly exercising their own decision-making authority or is receiving assistance from a relative in that? And I guess the recommendation would be, because I literally can't think of anything else, like the CCS or something attesting to that, or just some independent entity rather than whether or not they put people or assisting them on their service agreement or something like that.
Okay, great. Thank you. Do you know? Go ahead.
Yeah, if nobody else does, I have
Go
another.
ahead, Beth.
So with regard to the support broker and day-to-day administrative supports for 40-hour week limit, I'm assuming, I know we've said day-to-day will be 10 hours a month is what's proposed, and support broker. This is suggesting that a support broker cannot work for more than 40 hours a week and be paid as a support broker, even if they have 8 clients, or right? So we're limiting, this is what this is really doing. And I just think it's overreach to say that a person can't work more than 40 hours. If that's what they choose, CPAs work over 40 hours, doctors work over, if that's what they choose to do, I don't think we should limit a person's ability to do that. I understand the limits within one person's budget, but I don't think we should be telling people what hours they can or cannot work. So I think that's overreach.
Okay, thanks. Anybody else? Okay, we have
A follow-up question, Beth. So you're saying setting any kind of limit would be overreach, or is there another kind of recommendation for what a limit should be? It's just any limit?
Yeah, I mean, I don't, right, because my understanding is you're proposing that a support broker, that if I'm a support broker and I have 10 clients, I can't be a support broker for more than 40 hours a week for all 10 of my clients, 40 hours total. And I think that is telling someone what they can and cannot work is outside of DDA's role.
Do you have any thoughts on a caseload? We have some situations where a lot of people, huge caseloads. Matt, have you seen any that you could share?
I guess tell me if this is wrong, DDA, but let me put some words in your mouth. I think the problem we're trying to solve for is situations where we routinely see billing of 80, 100 hours potentially for a support broker. So I guess the question to me would be, how do we limit that in some way, potentially? Under review, there's no way to determine whether that really happened or not. And to your point, it could be that there's certain circumstances, people are working really hard or whatever, but there's no way to monitor then whether that's Medicaid fraud or whatever. So I interpreted this as some looking for some way to set some sort of limit on that to ensure that there's not Medicaid fraud. So is that correct?
Yeah,
I mean, I think
the
reason,
if I just 1 second, as we put in on the slide is really, we want to ensure quality services and timely responses, okay? And so Matt has shared, and Matt is from a financial management counseling services provider who sees different billing situation. He shared some examples related to that. So we are doing it to ensure quality services, timely services, and to address financial integrity and accountability, which is part of the requirements, which is some of what Matt is speaking to. So we're open to recommendations, and we're really seeking that. But we do have some support brokers with very large caseloads billing a lot of hours per week that we have concerns about the quality of services that are being provided and our ability to continue to monitor and assure our assurances for financial integrity and accountability. So again, we're open to recommendations so that we can address those challenges.
So the things we're trying to solve for, as Rhonda just mentioned, around quality, et cetera, response times, any recommendations on how we can ensure those things happen would be welcomed from our support brokers or folks who are doing the day-to-day administrator role. So thank you, Beth, for your suggestion. But that's really what we're trying to solve for. And there might be other ways. Matt, you mentioned caseloads, or Rhonda did. So we're open to suggestions.
Hi, this is Najla Wortham. I just have a question. Oh, sorry. I know we mentioned earlier regarding a form that you guys were going to be looking at other states and how other states are managing that process. Have you guys considered having the conversation with other states on how they are managing the support broker limitations or caseload levels or things of that nature, so that we can maybe have a clearer picture on what a path would look like forward, what other states are doing? I think it would be helpful.
Yeah, we actually just came back from the National Association of State Developmental Disability Directors Conference, and the Deputy Secretary and I were able to attend that. Self-directed services and monitoring and safeguards is one of the topics of discussion that was not only in the Directors Forum, but also sessions related to that. So there are concerns in various states related to how to do this. So there are things that we heard, such as increased monitoring and supplemental monitoring questions that could be looked at to include for people who are self-directing, particularly when you're utilizing legally responsible individuals, legal guardians, et cetera. So we did network with other states to find out what they're doing and intend to partner with them to have ongoing discussions related to that. but it is concerns that we're hearing nationally. And we're open to interest in ideas. So, please with your comments and your public comments, share recommendations so that we can address that in a fair way, but also to ensure quality services for people.
Has Applied Self-Direction released anything related to this concern?
Related to this concern, they were at the conference and did share also, that there are challenges within it.
This is Stephanie Watkins. So I work as a support broker, and I average, and Matt can do the research and attest to this, but I average probably about a total of 110 to 115 hours a month, right? So less than 30 hours a week. I work far more than that, but that's what's billable, right? So I think I run a very ethical business, but there are weeks where individuals don't get paychecks, right? And we're working countless hours to try to resolve pay issues. I've had weeks where I have billed 60 hours a week, and I have worked hard those 60 hours, and people have been in crisis. This makes it so that I'm now out of the picture, but the way that this new amendment is written, there's more on the support broker. There is more to do as you've removed a lot of the role of the day-to-day admin. So what you're going to end up doing is hurting the participants, making it more challenging for them to self-direct because the support system around them is now very limited as to what they're allowed to do for them. So I agree with Beth. I think this is a rule that is put in place to try to stop those that aren't doing it right. And I think we saw that in the manual, a lot of that. And I think that we, as a group, maybe we need some kind of work group that really looks and digs into this, that what are ways that we can protect, the integrity of the whole program while kind of limiting those that aren't doing it correct. How do we weed out the bad ones, basically, without hurting the ones that are doing it right? And I think we need to come together and maybe put some heads together to figure that out.
I also have questions in the chat too.
All these comments should be open.
Hold on one second. Go ahead, Matt.
Just maybe the word routinely exceed or something like that, so that that there is some flexibility there for those types of things. Whether it's 40 or 50 hours, whatever that is, but just that they do not routinely exceed that, so that in an audit, if it's constantly a certain amount, that's a different thing.
Okay. So Emily did have some comments in the chat. Her first one is, with the amendments, we should be thinking about how the different agencies help participants through self-centered plans. So thank you, Emily, for sharing that. She also noted, right, these are all, she also noted, how will the financial or fiscal management providers work with self-directed services be affected by the amendments? Will these changes affect how long it will take for staff are paid? I don't anticipate any delays in payments related to that. Matt's in the room too, he's saying no. So the amendment would not affect payment delays. And then Emily also noted, with constant changes to case managers, how will they keep up with these changes or amendments? So that's a great question, Emily. And so in general, what we will be doing with the amendment, with the approval, with the items that go forward and get approved by CMS, then we will be working with our coordinators of community services, our financial management counseling service providers, the Office of Healthcare Quality, and others, our Medicaid partners, related to the implementation and changes related to the programs based on the approved waiver that goes forth. So thank you for sharing those. So let's go to the next section so that we can keep going and have some additional discussion related to some of the proposals. And so the next section relates to technical changes to align with existing policies. And so we're going to share some examples that are aimed at ensuring our consistency across the policies and the practice in the waiver application. You go to the next slide. So this slide is an example related to behavior support services. And so what we've done is we've added into the waiver application specifically that behavior support services should be provided holistically, including the assessment, consultation, behavioral strategies in all environments, including employment day, residential programs. And we also noted that there may only be one behavior support service provider authorized at a time to support the participant. The reference to that is in our behavior support services policy. So on the right side of the slide, you'll see the actual policy reference. We've included the link there in the section so you can look at it, but you can see we use the same language and put it actually in the waiver application. Next slide, please. In terms of our meaningful day services, we added in the provider qualification section and in the waiver application, the employment training requirements. And so various examples were noted in there. We noted as one example under employment services that for discovery, job development, and self-employment development supports, that the requirement would be for proof of competencies related to completing and passing some of the national standard or tools that are used, such as the Certified Employment Support Professional Exam through the Association of People Supporting Employment First within the 365 days of beginning the role. We added that information, which is currently in DDA policy stat related to meaningful day services training policy. So the link's there that you can click on and see that. But basically we did a crosswalk and incorporated that in there. And also in consideration of things that are noted on the DDA training matrix, which has been out for some time. Next slide, please. And then in terms of CPR, we added to a lot of our services the requirements for that hands-on in-person component. During the public health emergency, there was an exception made due to the requirements for distancing, et cetera. But once that was lifted, we need to ensure that people are able to perform the actual CPR component. So that's required to be a hands-on in person. And we've applied that to the various services. A lot of our services require CPR and first aid. And that a reference to that would be that we've got it already outlined in the self-directed services comprehensive policy. So I'm going to pause there. Is there any questions, comments, or recommendations related to this or other examples that you may have of amendment proposals that are actually coming right from the policies that we're just incorporating so that we're being transparent and consistent with our language?
Is the Certified Employment Support Professional Exam also for those in self-direction? Is it for both?
Stephanie, can you hold for a minute and raise your hand and we'll call on you? Matt, go ahead.
The behavioral support, the idea of having one BSS provider at a time, is that in waiver guidance, or is that, I mean, let me put it this way, is it possible to have two different providers for a person? I know it might be a technical thing in LTSS or whatever, but we're running into a lot of issues where people want to choose a different BSS provider for each environment. Often when the provider offers BSS as an add-on service, it works better for that provider to have their own in-house services in terms of training their own staff, and that they have more control over their staff. So it's a better service that people are getting having two BSS providers able to bill. Is that possible, or is that?
So really our position has been in our policy stat for some time is that we really should look at behavior support services being holistic and looking at all environments. So really serving the individual holistically and comprehensively versus in isolation for residential or day or other settings. So that's our current standard and our position currently for best practices to holistically support the individual, not for the convenience of the provider and the model that they're doing, but really to be looking at that individual as a whole. But please feel free if you'd like to make a recommendations related to that, or anybody, we're open to considering any and all recommendations.
Aside from convenience, I would just say that, I mean, I think it's for us actually more related to philosophy in terms of the provision of behavioral support services. So if we don't agree with the philosophy of the other provider, I'm not willing to let them train our staff on a plan or something that we might not agree with. So it's finding providers that are philosophically aligned on certain things. Like we don't use restraints, for instance, and
Mhm.
perhaps another provider would do that, or, so they might write a plan in that way, and we don't agree with that. So it's hard to, so there's other elements to it other than staff training and stuff like that, I guess.
Yeah, I appreciate that. I would say that if you have situations like that where there may be conflicts within the team or concerns, that you reach out to Dr. Meg DePasquale, who's here with us today, our director that oversees that. We also have excellent additional behavior support staff within the regions. And I'm sure we're happy to meet with you and support that team dynamic and work through those concerns.
I mean, we have, and we routinely do, but that's just what we run into essentially. It
Okay.
keeps happening.
Great.
So-
Stephanie, I'm sorry.
And what I'm
Robert.
hearing, Matt, is this something you would like for us to take into consideration?
Please. I mean, I think us, and we've heard that from other providers,
Yeah.
It's just the idea of having, multiple VSS providers. But
Thank you. We'd also love to hear from other providers, what their thoughts are on this, especially if, how to address differences in philosophy.
Stephanie.
Will there be new training requirements for like ongoing job supports? Is that going to require somebody to have the certified employment support professional?
Yeah, as noted in the application, and Stephanie in the room, Stephanie Jones can correct me if I'm wrong, but it's my understanding that ongoing job supports does not require the anchor training. So my answer would be no, that's not required for ongoing or follow-on support. It is required, the certification is required for discovery and the other ones that I mentioned, which included, let's see, discovery, job development, and self-employment development support do require passing the exam for certified employment services professional. And that's noted within the waiver application. Okay, Matt?
in policy stat for the meaningful day training, or whatever it's called, there are a few additional trainings required for ongoing that they don't require the CSP or whatever, but they require those additional trainings. Are those going to be removed from policy stat, or will they be still required and added to the waiver?
They would still be required. I believe we added them to the waiver, but we can follow up and check. Well, why don't we go to the next section? Okay, so the next section is other requirements. And so if you go to the next slide. Get myself organized here. So the first one relates to slots. And states have the option to include reserved categories, or what we refer to as slots, for specific priorities that are noted within a waiver application. The DDA operated Medicaid waiver programs, we have several reserved categories or slot categories that are prioritized. So in our amendment proposal, we did look at the three programs because we're consolidating them and made sure that our overall total slot count includes all the current active participants that are in the program. So the number greatly went up. We also increased our crisis resolution reserve slots and our transitioning use slots in the Community Pathways waiver, and added a new deinstitutionalization category. We also have proposed to discontinue the waiting list equity fund slot category, and that's because during the legislative process and with the budget bill, the decision was made and authorized to use those funds differently, to use those for current services being rendered versus offering new opportunities for individuals. We also are proposing to discontinue the End the Waiting List Act category. We do not have any designated funding within our budget to support this category, but it's important to note that every year we support about 1,000 individuals that come off our waiting list, which far exceeds the proposed 250 that was noted in that category. And then we've also noted to increase the state-funded slots for year 3, but we would also discontinue them for year 4 and 5. And the reasons related to that includes that We have a focused enrollment effort for state funding right now. That was also part of the budget bill for us to support and help individuals that are state funded to be enrolled in the waiver program. And then in the future, if an individual is disenrolled from the waiver program, they have that right to appeal and go through that appeal process related to that. Lastly, I would just say for slots, it's important to note that at any time that we get additional funding or authorization for priority categories, we can amend the waiver programs and request additional slots. Can you go to the next slide, please? So this slide relates to cost neutrality. And in terms of cost neutrality, can you go to the next slide? Thank you. We have updated our cost neutrality projections for year 3, 4, and 5. So as mentioned, a waiver program is good for a 5-year period. And so for year 3, 4, and 5, we've updated our projections. Historically, the projections were based on not only the Medicaid services, but also it include non-allowable facility costs and state-funded services. And so working with Hilltop as they looked at actual claims utilized by participants in both service delivery models. They did an analysis and determined by that the margin between what it would cost to support people in the community under the waiver program compared to the cost to support them in an institution, which is what cost neutrality is about and a federal requirement and assurance we have to have, that difference is narrowing pretty quickly with about an annual difference of about $35,000. Again, the actual costs include Medicaid claims for both models. It looks at the institutional costs at Holly Center and Potomac Center for Medicaid claims. In both models, you have to also look at Medicaid state plan services, so costs for Medicaid for doctors and pharmacies, et cetera. But it does not include state funding that may be authorized for individuals who are at our state institutions that may be going out and attending day programs. Next slide, please. This slide relates to community development services and community activities. We had a question or concerns raised related to community activities. So we just wanted to share that we had proposed no changes related to participating in community development services, community activities. The community development services information is currently noted here on the right side for the reason that's what we have currently in the waiver application, and we made no changes to community development services in terms of those activities. So that means in terms of peer advocacy training and supports and participating in People on the Go or other type of activities, those are definitely available under the community development services. Go to the next slide, please. And then related to transportation and day trips, our proposal was noting to not include day trips as part of an allowable option under our transportation. Transportation services, as noted in the waiver application, are specifically designed to improve the person or the family caregiver's ability to independently access community activities within their own community. In the waiver, it notes that community is defined as places the participant lives, works, shops, or regularly spends their day. And so we want to continue to support community activities and financial accountability and integrity. So those are some examples of some other requirements that we have noted in the waiver. So before we go into some of the new opportunities, I wanted to pause and see if there was any questions or discussion from the council on those items. We have Matt in the room. Hi, Matt.
This is Matt. Related to the number of slots, specifically for Money Follows the Person and deinstitutionalization, I think it was 45 for MFP and 10 for deinstitutionalization. I think the rate at which that technically occurs is much higher in terms of people going out into a nursing facility and then coming back. They're typically, though, just given back their waiver services. I guess my question is, how much do the number of slots actually matter? Because it probably should be higher if we need to reserve capacity for that kind of situation. But
going in and out of institutions?
Yeah, because often like the institution applies for long-term care Medicaid and that application doesn't get processed. So they're still technically enrolled in LTSS with the provider. even though they're at an institution. And then by the time they come out, it's like they switch to the LTC and then right back to community or whatever. So they don't lose the slot per se.
Yeah. So I know we're getting a little technical,
Yeah,
Matt.
so that's why
I'm happy to talk to you a little bit afterwards too,
Yeah.
but I would say in general, the slots that we have proposed to continue and the adjustments we made were based on trends for people actually entering those slots. Keep in mind that when an individual leaves the program, maybe Robert goes in the hospital for a little bit and has to go to rehab, and he's in there and he's disenrolled, he can re-enter his slot and not have to go through MFP or deinstitutionalization. So there's that opportunity to re-enter in that slot. There is also the opportunity to capitalize on the MFP because we get an enhanced match, so we look at that. But the projections that we did, again, were based on trends that we've been seeing and closely tracking, and we can, again, increase them down the road if we need to, if we're seeing we're going to exceed those. But
Yeah,
thank you for
that
sharing
is the case for most people, so I just want to make sure it wasn't going to jam us up.
Yep.
Just make sure that could keep happening. Cool.
Yeah, thanks for sharing that. All right, let's go to the next section, please. And so lastly, we just wanted to, and go to the next slide, please. We wanted to share that before kind of concluding some of this overview, that there are new opportunities also reflected in our amendment proposals. And the first one being the consolidation. And we've been sharing that in our webinars in the last week several times. Really to streamline and enhance our service delivery system, we're proposing to merge our 3 programs together under one Community Pathways Waiver program. And by merging that, we feel that participants will be able to access the full array of support services based on their assessed needs, and it provides great efficiencies and opportunities within our programs, as noted here on the slide. We know that it's going to help us administratively, not only for our coordinators of community services, our eligibility determination division, the regional office, et cetera, but also will help in terms of individuals and families, knowing there's one program that's specifically designed to support people with developmental disabilities. And we won't have to have people disenrolling from a program who can no longer meet their needs to enroll in another one. Go to the next slide. We also have great new opportunities related to new provider opportunities that we've been sharing. So assistive technology, we're expanding to shift enabling certification, behavior support specialists or behavior specialists, we've expanded that to graduate level professionals, counselors working, master level social workers, and board certified behavioral analysts. For environmental modification, we try to streamline that. So we'd be really looking at individuals with the Maryland Home Improvement Commission and using that entity as recognizing the quality and professionalism of those services. For our mentors, we've talked about really focusing on people with lived experiences and not a bachelor's degree. And then for our family caregiver and training, really looking at expanding that so that an organized healthcare delivery system can be utilized to quickly facilitate the payment of the training and the workshops. Can you go to the next slide, please? And then in terms of services opportunities for assistive technology, we're adding a monthly service category and also adding smart home devices. So we're hoping that that's going to be helpful. We're also updating behavior support services being able to be provided for individuals in medical daycare. And then also under our transition services, supporting individuals to be able to get that training prior to transition from an institution. So pause there. Are there any comments or questions related to these additional new opportunities?
It has to do with the number of slots, if there are numbers of slots. That's my question. Are there numbers, is there a cap on the number of people that are serviced under family supports or under community supports?
Yes, there are capped for all 3 waiver programs right now.
So will those caps remain even if they are all within one?
No.
So how are we protecting it against using, like what, will it become lopsided if all of a sudden now we're serving young children as opposed to adults, and we've used the money for the young children and there's not the money set aside for the adults? Is that a risk?
Yeah, that's a great question. So in DDA statute and law, currently it says that we need to have a waiting list, and the waiting list needs to be categories as crisis resolution, crisis prevention, and current request. We serve all ages, so it's not ranked based on age, whether you're a child or an adult. So if you're a child or an adult in crisis, we would serve you first from that. So what we would do is we have available slots. We would say, okay, we got 20 slots that we're able to support individuals because maybe 20 people moved out of the state. We would say, what's the top 20 individuals based on when they became in that category? and we would offer the opportunity to apply for the waiver program. We have all those other reserve categories. So we have transitioning youth reserve categories. We've got categories for military, which currently exist in the various programs, crisis situations. So those would continue to exist.
So categories would exist.
The current reserve categories would continue to exist as they're noted, with the exception of the ones that we've noted here and last week that we proposed to discontinue. The waiting list equity fund, the in the wait list act, the participant with increased need because they won't have to transition to a program, and the other ones that we talked about. So the ones that were in there will continue to exist.
Okay, thank you.
Okay. Can we go to the next slide, please? So a couple other things we just wanted to share. Yesterday, communication went out about a new webinar. Robert mentioned that today. If you go to the next slide, please. We are proposing to engage in another webinar with stakeholders next Wednesday from 12 to 1:30. As Robert mentioned, we're going to be sharing this information that we shared with you today. We're going to be seeking additional recommendations related to that. So we hope that you'll be able to help us in terms of sharing that information with your networks and the groups that you represent so that we can have that additional engagement next week. Related to that, we wanted to see if the council had any additional input related to this webinar next week. We'd like to present the information we shared today, but is there any additional information or strategies that you would think or changes to how we presented this information to you so far that we should take into consideration for the webinar next week? And I think Stephanie, you had your hand up, so is there any recommendations related to the webinar next week?
So the SDN has been getting a lot of questions from members, emails, Facebook page, all kinds of ways. So we have quite a long list of questions. We're kind of trying to organize those and consolidate those into more meaningful questions. Could we get them to you ahead of time to kind of help guide you so you kind of see what these are majority questions, like we're getting 50 people have asked this one question. Is there a way to get those to you ahead of time to just kind of help the flow on the second?
Absolutely. We're happy to consider those. If you could get them to us as soon as possible. Today is what, Thursday? Is it possible that you could give me some of the major themes tomorrow?
Yeah. And the best way just to email you directly?
Yeah, if you could email me directly, that would be great. Any other thoughts? Was this information helpful? It's a little bit different than what we presented last week. So we want to make sure that, we're sharing and kind of engaging some of those themes and answering some of those questions that we've been getting.
I appreciate it, the way you broke it down. Thank you. That's much clearer than last week.
Last week was a lot of information, but hopefully it was good.
It was good, but this is
Okay,
better and visually better.
Appreciate that. Matt, did you have a thought?
There's been a lot of discussion around dedicated hours, and there wasn't that didn't fit into those pieces or whatever. So in terms of the webinar, I think you're going to get a lot of questions about that. So you might want to address that.
In terms of dedicated hours, can you be more specific?
Yeah. So in community living group home, as an example, the requirement for the behavioral support plan or nursing plan of care to specifically denote one-on-one service. The section after that also talks about sharing services. If someone stayed home, if they're retired or something, it provides for the ability to do that. But it doesn't say that that's a reason you can get them authorized. It just says you could share them if you had them in that circumstance. So I think there's concern about people who are retired or refuse to go to a day program, and that wouldn't necessarily be tied to a nursing plan of care or behavior support plan. DDA has used that sort of unless otherwise authorized by DDA language to give themselves the discretion in those circumstances to allow those types, because everyone knows that kind of thing happens. So I would recommend including, other criteria in there potentially, or giving DDA the discretion to, acknowledge those circumstances. Because you're kind of removing that from yourself. I'd be worried about a Medicaid audit requirement, for people that are retired and stuff like that.
Okay, thank you. Great. Stephanie.
One last question. Is it possible to get a copy or for the public to see the Hilltop study that's basing the cost neutrality numbers?
I think to look into that.
Yes,
I
we
don't know
can.
how,
Yeah,
if we got an official report or if it was a discussion.
We'll circle back with UMBC.
There's been a lot of questions about that. That'd be great.
Great. And remember, the cost neutrality is not based on authorized budget. It is based on actual Medicaid claims. And so the Hilltop Institute is able to access and utilize Medicaid claims as a research institution. And so they're looking at actual Medicaid claims for waiver services versus institutional costs. And remember, institutional cost does not include facility costs or state-funded services. Can you go to the next slide, please?
Before we move on, Rhonda, just a comment. If you all think of other things you feel we should address next week, please either put it into the chat box here or send it directly to Rhonda so we can make sure we include it. Maybe while you're driving home, something comes to mind.
Yeah. Can you go to the next slide, please? We also shared updated information and communication this week related to the public comment period for respite and support services. For supported living. Can you go to the next slide, please? We did discover that after we initially posted our proposals, that two of the proposals was not reflecting on the website. And so we want to make sure that individuals and the public has the full 30 days. So we extended the time frame for 5 additional days for these 2 services only. Please note that if you'd like to share all your recommendations at one time with the original due date of July 8th, you can do that. You don't have to wait and delay your comments and send 2 separate comments. So we encourage you to submit them all. But if you need additional days to consider the respite and supported living proposals, you will have the additional days as noted here till July 13th. Next slide, please. We've included in our PowerPoint some additional resources. These are also available on our dedicated webpage that you can look at. So we've got the actual link to the dedicated page. The second bullet here is the actual CMS, or Center for Medicare and Medicaid Services technical guide. So we refer to that a lot today. You can actually look at it. It's a document that gives you all the rules and requirements for the waiver application. They'll go into every appendix C. They'll talk about services, the safeguards, the assurances, the financial integrity, and accountability. And then this last bullet is a recent presentation that CMS did when they updated the technical guide and the requirements that we have to submit. So that's going to talk about legally responsible persons, legal guardians, relatives, the assurances that we had talked about today. Here, the next slide, please. We've also included on this slide, and we've been pushing that in our communications that have been going out, links to the PowerPoint presentations we did last week, and including the recorded webinars. So people can go in and review them if they want, or if they want to look at a specific topic, there's another opportunity for them. You go to the next slide, please. So before we open it up for further public comment from individuals outside the council, Karen, we'll turn it over to you to see if there's anything else you want. Recommendation work group as part of the discussion that we are having on this topic.
Thank you. So the Waiver Advisory Subcommittee is going to submit a letter directly to you and to the Deputy Secretary, kind of a general letter before we go any deeper. So you'll get that in a couple of days. And we recognize, number one, that there are mandated changes from the legislative action as well as from the federal requirements, and we really appreciate. Today's presentation was presented in a really clear way for us to be able to discern between why things are happening and why the changes are being recommended. We have 2 really general recommendations that you'll see in our letter. The first is that, and I just want to reference the discussion that Stephanie brought up about the support broker hours and so on, that there are changes. We're recognizing that there are amendment proposals in here that definitely need to be addressed, but our concern is that there needs to be more feedback loop as well as time for research. We recognize that you are on a tight schedule because you have a mandate to get this done, and recognize that you have to get that through. But one of the things that we appreciate you sharing with us often is that we can do as many amendments as we want. And so some of our recommendation will be that we continue to have a dialogue about some of these things that are not mandated. So we'll send you that directly. And the other final item that we are recommending to you is that these separate guides be created in plain language to ensure that family members and people with lived experience understand the impact to them, and so that we look through that. So those are the two primary things that we're going to send to you in our upcoming letter. But and just ask if there's anybody else that has anything they want to add from the committee.
The people with lived experience group, you want to share to this?
The lived experience work group has continued to meet, and our main focus has been discussing the waiver amendment. Our members brought forth numerous concerns about many aspects that we would like further clarification on throughout the amendment. Like the other work group has said, due to the limited time frame for public comment and the extensive breadth of the proposed amendment, it is the opinion of the lived experience group that the amendment only encompasses the changes and policies needed to comply with the federal and state mandates, as well as the already present policies. For policies and changes solely brought forth by DDA, more time and plain language is needed for the council and public to make a proper and informed recommendation. This is Charlotte, by the way.
Thanks, Charlotte. Appreciate that. Great. Any additional comments from the council? We wanted to open it up for a few public comments from non-council members related to that. Yeah, just 1 second. We're gonna give you just a couple minutes because we have some additional things that we want to do too. But so if you can take 1 or 2 minutes and share. And again, just in general for everybody, the public comment period is still open, so we are definitely interested in your written submitted ones too. So if you want to introduce yourself and share a couple things, that would be great.
Yes, thank you. I'm Karen Smith, and my daughter has been in the self-direction program for over 18 years. And I'd just like to echo what the work group said and what the lived experience group that Charlotte said, that, we all saw the manual come out in October, and I think it was very rushed. And in November, and we've had I think 4 or 5 manual changes. And a lot of that was because it wasn't looked at super carefully. There were things with the ABLE account, the special needs trust. There were support brokers that actually shut their business down because they were told that they couldn't provide more than one service at a time. And I think some of these things were very unintended consequences. No one at DDA realized all of these negative things that were going to happen to participants. And I think we're really rushing things. And I would echo what the 2 work groups have said, that we really need to keep this waiver amendment to the mandated things right now. And we need to work together as just really thoughtful stakeholders to bring everyone together so that we don't have unintended consequences, because I've seen some really negative things happen. I have personally 75 clients that are not just mine. I have a support broker company. And so it looks like, based on, because Fellow has us put down just one name. So it looks like they're all mine, but I have other support brokers that work for me. So there's a lot of things that people just don't know. So my second thing is day-to-day admin. Day-to-day admin was, in my opinion, from what I've seen from the legislators, it was removed. They wanted it removed from IFDGS so that it wouldn't be capped at 5,000. And what happened is, if you look at the 3245 rate times 10 hours a month, that's less than 5,000. And I personally have seen wonderful teams create day-to-day admins where, like my own daughter has 10 staff that work for her, and it's like a small little group. Try running a restaurant or try running a small business with 10 staff and not having a day-to-day administrator, and saying that day-to-day administrator can only do 10 hours a month. So I think that has to really be looked at as well, as to what the legislative intent was versus how it got put and how many hours, and the fact that the work group has recommended more like, 20 hours for day-to-day admin a week, not 10 hours a month.
Okay, great.
Thank you.
Thank you.
It's actually one of the points that I forgot to underscore. So the premise behind the 10 hours a month is based on the actual appropriation that the MJA approved to preserve day-to-day administrator as a service under the self-directed services model. So they gave us $7 million in general funds, and with the match, there's another $7 million, so that's $14 million, and we anticipate a 60% utilization rate. And so we wanted to make sure that anyone who wanted to access that service based on their assessed need could access that service. And even the actual math came in a little under 10 hours per month, but we went up to 10 hours a month. Now this is, once we're operating in that future state, we'll continue to be able to monitor utilization and possibly make adjustments in a future amendment, but that's sort of the premise behind it.
And if I could just respond to that, because I completely understand that. I will say, I'm working with a group of concerned citizens of Self-Direction Maryland, and we were working with a lobbyist to discuss all of this. And when we first started with it, it wasn't to ever ask for more money. It was to use the unallocated funds that the participant already had allocated. And so it actually increased things by allowing participants to then ask for additional funds. So that was never the intent. So I don't know if there was something lost in translation, but it was never to ask for more money. It was to be able to have budget authority and employer authority and be able to use the unallocated funds that the participant already had approved. So I think it just got a little lost. So I think we need more time and more conversation about that. And I'd love to be a part of having any more conversation with you about that and working with others to solve the issue.
Thank you.
Thank you.
Rosemary. Rosemary, if you'd like to unmute yourself and share a couple thoughts.
Hi, thank you so much for taking my question. It kind of goes to the same theme that you've been hearing from the work groups on the council, but a little different in that I'm wondering how DDA will implement and operationalize the amendments within existing person-centered plans.
I'm not sure I fully understand your question, but as I mentioned before, we will be moving forward with additional training, guidance, update manuals, working with our coordinators of community services related to the amendment proposals once they are fully submitted and approved by the Center for Medicare and Medicaid Services. We have already been working internally with our LTSS Maryland team, our eligibility determination teams related to updating person-centered plans so that the day-to-day administrator would be a drop-down option, including the assistive technology monthly service option. So all those coordination and operationalizing discussions have been in motion. And as I said, we'll be sharing additional information and guidance as we move forward. So thank you for sharing.
To clarify my question, what I'm asking is that the October 6th implementation date of this amendment, all of the changes that will be required to person-centered plans, for those plans that are in an active state, will they require revisions?
So again, Rosemary, I'm happy to kind of connect with you offline, but I would say a couple things. With the consolidation, there will be no revisions or actions needed by coordinators of community services for people who are in family supports or community supports to be noted and enrolled in the Community Pathways Waiver. There will be no actions needed related to person-centered plans. We will do all that on the back end with our technology to basically update the current authorized plan to be reflected as a Community Pathways plan. And again, happy to connect with you offline if you have additional questions.
Thank you.
Go.
Great question. We should add it to the deck for next Wednesday.
Mm-hmm. Let's go to Mary.
Hi, thank you for allowing me to speak. I have, I'll be super quick as I can. As far as legal guardians go and not making decisions for services and things like that, if a court of law has already determined that a legal guardian is the person who is going to make the best decisions for an individual, why is that called into question with the DDA? That's one question. Another question is about limiting support brokers to 40 hours a week. Are other services also going to be limited to 40 hours a week, like nursing and CCSs? Because that, in theory, should also be quality controlled as far as the amount of time, so that we are ensuring that quality services are being provided to the participant.
Yep, thank you for sharing that. In terms of your first question or comment, as we shared in the slide deck, there are new federal requirements that requires us to outline the substitute decisions or substitute agreement for when individuals who utilize a legally responsible person, a legal guardian or relative, has decision-making authority over the individual's services and providers. And so that was a discussion we had earlier about reaching out to our national association and seeing what other states are doing, and also asking the council and the public to share your recommendations into the public comment process. That would also align with any recommendations for limits to other services. We already noted that personal supports and other services are limited to 40 hours. And so if you feel you'd like to share those recommendations, we can absolutely consider those.
Well, it was more for the vendors that are support brokers and other vendors like nurses and CCSs
Yep.
and things like that, working more than 40 hours a week. And my final question is this: there is a mismatch. I would like to know why the DDA will not redo or revise the current reasonable and customary rates for vendors for CDS. There's a mismatch in funds because of the community development 1-to-1 and 1-to-4. The maximum that vendors can charge is the same, but it's funded, the 1-to-4 is funded through LTSS at a much lower rate. So when they're funded at 1-to-4 and the vendor is charging 1-to-1 because they can, the participant does not have enough money in their budget to take care of all of the things they need to take care of. So I had made the recommendation that the DDA look at the reasonable and customary rates for vendors and simply split out that one line for community development 1-to-1 and 1-to-4 into two lines because of the difference in funding in LTSS.
Yeah, thank you for sharing that. In previous conversation with the Self-Directed Advocacy Network of Maryland, a decision with the previous administration was to utilize the same rate. Individuals then would need to make the decision whether they want to use it or not. The rates that are listed for reasonable and customary are not guaranteed. Those are things that the employer record. The participant who is self-directing would then work with their employees, their vendors, and DDA providers to work out and negotiate based on their budgets, their priority, their business model. So please note that reasonable and customary rates and wages, whether you're talking about employees, vendors, or DDA providers, is not a guaranteed rate from that perspective. So
And I do
with that,
understand that. Thank you.
we have a few other things that we need to kind of get to, and I'd really like Warren Waters to be able to share if he's still available. So we appreciate the time. If you're able to stay on with us, we'll still do a couple additional things.
Yeah, and to that, again, we're going to have another opportunity to engage with you all next Wednesday. And we are devoting an entire 60 minutes to hear from you, from the public. So there will be another opportunity, and just want to thank you all for all of your recommendations and comments up to this point. And I hope that you all plan to attend next Wednesday as well.
Robert, why don't we do the program sustainability to talk about the numbers, and then we'll probably need it in there.
Right, so what do I do? So there's a slide in the deck. It's more informational than anything, just to kind of give you a sense of how many folks are receiving DDA services, and how many folks are on the waiting list currently. We've also included an estimate of, based on Maryland's population of 6.3 million people, how many would be estimated to have some form of an IDD. So this is just informational, but it's also, as Rhonda mentioned earlier when she talked about cost neutrality, we are really shadowing that glide path, and we definitely don't want to pierce it. And as we committed to during session, we are putting together a program sustainability work group. So more information will be forthcoming about the work group. We want it to look very similar to the makeup of this advisory council, so that everyone is a part of that, and we're all at the table working together to not only sustain the program, but to create enough capacity so that other people who need DDA services have the opportunity to get the services that they need as well. So more information will be forthcoming on that, and we hope to have the first meeting next month.
Thank you, Robert. So I know we're at our 3 o'clock time period. A lot of great discussion. We really appreciate the feedback related to the waiver amendment. We know that we didn't get through all our agenda items. We'll move the other ones to our next meeting, but we really felt that the priority right now was the amendment. And we appreciate not only the council members sharing their thoughts, but also the public that shared their information. So please consider joining us for the webinar next week, as we'll share additional information. A reminder, the public comment period for the majority of the services, appendices, will close on July 8th. Please feel free to submit early. We're looking and analyzing that now, but you do have 5 additional days up till the 13th if you need that for respite and supported living. So thank you.
What day will it be submitted to CMS?
Pardon me?
What day will it be submitted to CMS?
We're looking at July 17th.
Okay, so there is time from time the last person submits to give you a chance to look at it, decide if you're going to put it in the waiver.
Yeah, we will look at every comment.
17th. Okay, great.
Yep.
Good.
And just so y'all know, we are reviewing comments as they're coming in, so we've already started to, categorize the comments based on common themes. So we're not going to wait until the last minute, but we do anticipate at the last minute getting an influx of those comments, and we'll be working diligently to get through it. The secretary at the stakeholder roundtable that we held, I think probably 3 or 4 weeks ago, she talked about, hitting the reset button. And, we know how important it is to engage with you all so that together we can do what's necessary to ensure that these programs are sustainable and meeting the needs of individuals. We also realize that we have to back the talk up with action. So, it's kind of been a tenuous relationship over the past few years. And so we're hoping that you all give us the opportunity to prove to you that we're really serious about engaging with you, taking in your feedback, and making the best decision possible that would benefit most of the individuals in the program. So thank you all for that.
This waiver is a great chance to do that. I really
Absolutely.
think it's a great chance to show that.
Absolutely.
Great. Well, thank you, everybody. I'm here if anybody has any questions. Thank you, everybody online, for joining us. I wish you guys a great rest of the day. Stay safe, drink lots of water.
I would have loved